Hi, my name is Michelle Bruno, and this is my presentation on Norway's healthcare system. Norway is located in Northern Europe. It has a population of over 5 million. It is a small country with a low population density, so it's a lot of rural areas. It is one of the richest countries in the world due to oil production. It is a parliamentary democracy consisting of the state, counties, and municipalities. The basic healthcare system, I'll be covering the basis, coverage, structure, and how it is financed. The basis of the healthcare system, it centers on universal access, decentralization, and free choice of provider, which actually 99% of residents take advantage of. The coverage includes universal coverage, regardless of socioeconomic status or area of residence. It does include the European Union residents, and the European Union is an economic partnership between the 28 countries, fostering economic cooperation to make it easier to live and travel and work in Europe without having to deal with the borders. Undocumented immigrants have limited coverage that is limited to emergency acute care services. Everyone is covered by the National Insurance Scheme, which is the insurance. Private insurance is limited to about 5%, and it's usually elective services. Items that are covered are prescriptions, preventative services, including screenings and immunizations, primary care coverage, chiropractic, specialty, as long as primary care okays them to go, acting as the gatekeeper, emergency services, radiology, lab, medical eye coverage, but that does not include glasses. There is dental for children and some adults with certain diagnoses, and nursing is also covered. Financing is 85% publicly financed, mostly through taxation at the central government level, counties, and municipalities. There is personal and corporate taxes. 15% is privately financed. That includes copayments and out-of-pocket services. Some examples of copayments are, and I did convert these, are about $25 for general practitioners. Specialists are $45. Radiology services were $30. Lab services were $10. And there is a maximum determined yearly, kind of like how Medicare is in the United States. The maximum is $300, so there is a cap. There's also employee and employer funds that are privately financed, and that is usually for supplemental coverage. With the healthcare history section, I'll be covering the 1800s, the 20th century, after World War II, the latter 20th century, and 2000s and beyond. The 18th century showed significant number of providers were established. Hospitals were also established, but both were scarce in rural areas. Municipality involvement was limited. Providers and hospital establishments were run privately or by volunteer organizations. The state and municipality in the 20th century took responsibility for public health. Hospitals were owned by churches, volunteer organizations, municipalities, and the state, so it was a variety, it was not consistent. After the Second World War, changes were made at the state level. The Directorate of Health Department was established under the Ministry of Health, which regulated the medical professionals, and the National Insurance Scheme was created in 1967. In the latter 20th century and 2000, in the 1970s, the discovery of petroleum led to economic growth. There was an increase in specialty services and ambulatory care. The counties became responsible for planning, building, and managing hospitals. But the central government did gain control of two of the large hospitals. In the 1980s, municipalities controlled the general practitioners. There were reforms to find a balance between state and local government. In 1998, there was an action plan for the elderly to improve provisioning in nursing care services. In 1999, there was an action plan for mental health to improve mental health services. 2001 was the Patients' Rights Act and Mental Care Act. 2002 showed the Norwegian hospital reform, which transferred responsibility from the counties to 5 regional health authorities, which there is now actually 4 as of 2007, because they combined them. Since 2008, there has been a lot of coordination reform between municipalities and the RHAs. There's been a focus on quality of care and patient safety. In regards to healthcare policy, I'll be going over the organization of the healthcare system, who controls the policy, and policy creation. This is the basic structure. It is Parliament, then the government, the Ministry of Health and Care Services, which controls the RHAs, who controls the hospitals and specialists, the Directorate of Health and other departments, the county, which controls dental care, the municipalities, which control general practitioners, nursing, and public health. Again, the healthcare policy is controlled centrally by the Ministry of Health and Care Services. The central government, the RHA, manages and is financially responsible for hospital and specialized services. The municipalities organize and finance primary health care based on demand, and the counties have control of the dental services. Healthcare policy creation. This is a quick overview. New policies can come from both inside and outside of the political system. For substantial or controversial changes, the government appoints a special committee to create a report. The report's then delivered to the Ministry of Health, where they decide to either abandon or present the report for public consultation. If it does go to public consultation, a policy draft is sent to organizations and other individuals that would be affected by the policy for their review. After the consultation process, the Ministry of Health decides whether to continue the policy draft. If they do continue that draft, the draft is submitted to the Council of the State or the Cabinet, which after that is then approved, is submitted to Parliament. A proposition, as either a proposition or as a report. Propositions would be legislative acts or bills, and reports would be items such as white papers. Subcommittee would then review and give recommendations to Parliament for a Parliament discussion. Parliament can then accept, propose amendments, or reject the policy. If it is an act and it is accepted, it would become enacted, and an accepted report would then be adopted. The Ministry of Health is then responsible for implementation and evaluation of the policies and reports. Okay, major changes in healthcare in the past decade. I'm going to review local government reform. In June 2014, the local government reform was passed by Parliament. It was the first major change in 50 years. Municipalities are being asked to merge into larger groups by 2018. This will be moving the power and responsibility to the municipalities from the centralized government. They will be given new responsibilities on top of the ones they already have, including rehabilitation and substance abuse, financing patient transport. They will be involved in financing reform, in nursing care, dental care, and supplementary benefits. The goal for the local government reform is to create a local democracy that can safeguard welfare and ensure prosperity for the nation. Thank you.